Bismillahirrahmanirrahim. I'm Dr. Saima Rafique, second year resident pediatric cardiology at AFIC. Thank you for giving me this opportunity to present at this August forum. I will be discussing management of a challenging case of right ventricle to pulmonary artery conduit stenosis with severe right ventricular dysfunction. My patient, 29 years old girl diagnosed with tau of pulmonary atresia, underwent Beatty shunt in 1996 in UK, followed by Rastelli repair and placement of an RV to PA conduit. However, her conduit got infected, requiring revision in 2011. During surgery, while doing sternotomy, cardiac perforation occurred due to adhesions and fragile necrosed tissue, and the patient had to be shifted on emergency femoral bypass. After necrotic tissue excision, a homograft conduit was placed between RV and PA. On post-op follow-up, there was a gradient across the conduit for which balloon dilatation was attempted in 2014. After that, the patient was lost to follow. She presented to AFIC on 12th June 2022 with a history of worsening dyspnea, orthopnea of about 5 weeks duration. Her physical examination revealed tachypnea, tachycardia, low oxygen saturation, and signs of right heart failure. Due to chronic ailment and poor clinical condition, the young girl was in severe physical and psychological stress and had a very low mood. Her baseline labs were within normal limit, except for a mildly raised serum bilirubin and markedly raised pro-BNP levels. Her 2D echocardiography bedside done revealed a huge right atrium with interatrial septum bowing into left atrium, dilated right ventricle with severe RV dysfunction, and an ejection fraction of 15 to 20% on eyeballing, with only a faint measure of flow seen across RVOT. Tricuspid regurgitation velocity was more than 3 meters per second, and a TAP-C measuring 6 to 7 millimeter. IVC was grossly engorged with spontaneous echogenic shadows. A contrast computed tomography study was done. This 3D volume rendered image demonstrate RV to PA conduit retroflexed acutely as it takes off from the surface of the right ventricle. It can be compared to the image on the right. The same image after elimination of the surrounding soft tissue, here we can see dense calcification of the conduit itself and a sharp angle at conduit RV junction. Upon curved planar reformatting, severe stenosis at that bend is evident, hardly measuring 2 to 3 millimeters. Pulmonary arteries did not show any narrowing, but the sizes were decreased, with main pulmonary artery having a z-score of -3. On the basis of history examination and investigations, RV to PA conduit severe stenosis diagnosis was made with severe right ventricular dysfunction, and replacement of RV to PA conduit was planned. However, it was a challenging situation dealing with a failing right ventricle, difficult anatomy due to multiple surgeries and interventions, and poor clinical condition of the patient. Regarding surgical replacement of the conduit, as a fourth redo surgery, challenges were the conduit itself, which was heavily calcified, adherent to the sternum. Moreover, we were fearing that a failing right ventricle with a very low ejection fraction might not sustain further insult of a cardiopulmonary bypass. A multidisciplinary team discussion involving peds cardiologist, cardiac surgeon, and anesthetist was done, and a comprehensive plan was devised for a very high-risk right ventricle to PA conduit stenting to bail out the failing right ventricle, with surgical backup in case the intervention was unsuccessful. It involved pre-procedure optimization of the general clinical condition of the patient, with meticulous invasive monitoring was done along with negative fluid balance, inotropic support, and anti-failure medicine with resultant clinical improvement of the patient. Once her clinical condition was relatively stable, a decision for very high-risk transcatheter conduit stenting was made, and planning regarding stent size and type was done. The extent of calcification and proximity of the conduit to the coronary arteries was also taken into consideration. Based on detailed CT analysis, 12 by 39 millimeter balloon-mounted Bentley cover stent with an introducer sheath compatibility of 9 French, which is the smallest possible caliber, was first selected. Difficulties with transcatheter approach were conduit anatomy, as it was arising from a heterotopic location on RV, had an acute bend and severe calcific obstruction with approximately 3 millimeter patent lumen. With this plan to undertake a very high-risk procedure in collaboration with surgical anesthesia teams, all the paraphernalia for open heart was brought into the cath lab. After induction of general anesthesia, peripheral vascular access was established by cardiac surgeon. In case the patient becomes hemodynamically compromised, emergency cannulation could be done and peripheral cardiopulmonary bypass established for surgical replacement of the conduit. After that, the patient was handed over to the cardiology team. Considering a very tight stenosis, unusual takeoff of conduit, severe tricuspid regurgitation, and dilated right ventricle, possibility of going through right internal jugular vein for better stabilization of catheter was also kept in mind, which was already accessed through 6 French radial sheath in place. The procedure, however, was started with the orthodox transfemoral approach. RV angiogram in LAO90 revealing tight stenosis. Before doing angiogram, RV pressures were measured, which were suprasystemic. Multiple check injections were given. As you can see, there is hardly any antegrade flow across the stenosed conduit. Conduit was then crossed with Terumo 035 glide wire. 5 millimeter non-compliant coronary balloon over 014 guide wire and pre-dilatation was done so that larger catheters that we were planning to negotiate across could pass. However, despite using the smallest French Judkins right heart, that is 4 and 5 French, we had significant difficulty advancing catheters over the wire across the stenosed conduit. Pressures were suprasystemic, there was severe tricuspid regurgitation, and RA was massively dilated, so transfemoral approach did not provide stability, and the catheters were pushed out after being engaged. Therefore, we went for transjugular approach and also changed the catheter. 5 French tick catheter, which is designed for optimum torque control and precise placement, was used from right internal jugular vein for better support by forming an elbow at the base of right ventricle. As it can be seen, our thought process proved to be right, and the bend of the catheter kept the position relatively stable, allowing us to pass Lunderquist wire and park it deep inside the left pulmonary artery, which due to increased body flexibility and linear stiffness proved to be the right choice. As we were anticipating difficulty in 9 French introducer sheath across, therefore before taking Mullen sheath, we pre-dilated the conduit with multiple balloonings with 12 by 40 millimeter wax 2 balloon. Nine French delivery sheath, which was the recommended manufacturer size, was placed in position, but due to relatively smaller sheath and multiple bends across the path, the stent got dismounted from the balloon while positioning. So we had to take that stent out, upsize the delivery sheet to 10 French, and then 12 by 29 millimeter covered stent was successfully advanced to the desired position. Multiple check angiograms were done through the delivery sheet to confirm final deployment position. The stent was then deployed, keeping the stenosed part in the mid. There was some degree of stent recoil, as it can be seen. Angiographic confirmation of stable stent position was obtained, and the sheath and wire were removed. Post-procedure recovery of the patient was smooth. She was extubated within 4 hours on minimal inotropic support with marked clinical improvement. After 24 hours, invasive monitoring was discontinued and she was shifted from intensive care unit to high dependency unit. This very high risk and a difficult task was accomplished owing to meticulous clinical monitoring and optimization before procedure, detailed planning involving multidisciplinary approach, general anesthesia that kept patient hemodynamically stable throughout the procedure, confidence of surgical backup in case any emergency happens, right approach that stabilized the catheter while parking the wire. Lunderquist wire itself, which gave optimal support due to its strength, and progressive dilatation of the stenosed conduit that led to successful deployment of the stent. Post-procedure 2D echocardiography showed improved right ventricular function, reduced tricuspid regurgitation less than 3 meters per second, and a well-placed stent with good flow across RVOT can be seen. Her most recent follow-up after 3 months showed marked improvement in general well-being of the patient, with echocardiography showing adequate flow across the stent and improved right ventricular function. Follow-up catheterization may be done if non-invasive assessment of right ventricular pressure suggests progressive restenosis.